Hello, friends. First of all, let me congratulate the Amrita Emergency Medicine team for conducting this wonderful conference and making me part of it. Let me share my presentation onto the posterior segment effects of trauma, that is, a retinal and optic nerve problems that can occur in the trauma. So, what are the problems which can occur? Scleral rupture, choroidal rupture, traumatic retinal breaks and dialysis, traumatic retinal detachment, Commotio retinae, otherwise called Berlin's edema, contusion injuries to the retinal pigment epithelium, retinal vascular occlusions, vitreous changes, and optic nerve injuries. We will go through these. Whenever it's a blunt trauma, force is applied to the retina without penetration, as contradistinct to when there is a penetrating trauma inside the eye. It is compression, decompression, overshooting, and then the oscillations which cause all the problems. The mechanism of injury could be coup or counter coup, just like in the skull. Shock waves are transmitted across the globe, and that will cause the counter coup injury as well. Direct rupture by blunt trauma is rather uncommon, but with a penetrating or perforating injury, it is very common. Indirect rupture, when blunt trauma occurs in the weakest areas of the sclera, that's at the insertion of the recti, or if there is a surgical site incision, etc. Visual acuity can be very variable depending upon the amount of trauma which can be seen, and diagnosis, you have to explore this conjunctiva, sclera, ultrasound, B-scan, then you can find out the perforation or scleral rupture. Treatment is by primary closure. This is an example of a scleral rupture because of blunt trauma. You can see that it was very ghastly and very severe at times. You may have to, remove the conjunctiva, open it up, and then suture it in different layers. Choroidal rupture can occur at the site of the injury or the site opposite to it. Could be anterior or posterior ruptures. And basically, the inelastic choroid, when forcefully compressed, it ruptures with Bruch's membrane, tears, etc. It can have complications like choroidal neovascular membrane. You can see a choroidal rupture here, which is underneath the retina with this, with a bleed all around it. If it is going through the macula, you will significantly have a loss of vision. Later on, it will cause a scar like this, and scar at the macula can cause a lot of problems. Retinal breaks and tears can occur when vitreous is forcefully separated from the retina. It can occur at the vitreous base, which is the periphery of the retina, to lattice degeneration, to the previous chorioretinal scars, or even at the fovea, it can form a macular hole, which causes a loss of vision. Retinal blood vessels and concentric retinal tearing. Sometimes the non-foveal tears are treated with laser, cryo, or scleral buckling, and the macular tear or hole can be treated with a vitreous surgery. These are some examples of tears. There's a bleed here, and you can see the tear which we have lasered all around. You can see the tear which is lasered all around. Retinal dialysis is actually avulsion of retina right from the ora serrata. And the anterior edge is the ora, which is the peripheral most extent of the retina. And commonest site in terms of a traumatic dialysis is supranasal. An indirect ophthalmoscopy can be done to actually pick that problem up. This is a case where you can see there's a superior nasal dialysis here, and you can see there's an avulsion of the retina right from the ora serrata. You can see the ora serrata which is torn, and there is a retinal detachment here. Traumatic retinal detachment is more common in young males, and it is associated with the superior nasal dialysis in about 1/4 of the patients. Inferior temporal dialysis in about 30% of the patients. You can see this is a large tear superiorly with a retinal detachment, which is quite like this. This is a 13-year-old boy, a small case, illustrative example. After blunt trauma while playing football 1 month back, you can see that the patient came with loss of vision. On examination, the vision was about 1/60. And you can see here, we are going inside. This is the retina which is flapping around. That's the retinal detachment which is seen. Now we have to remove the vitreous, first of all. So this is about removing the vitreous right in the periphery. And once the vitreous is removed, here I am diathermizing the tears. There are multiple tears, all the tears. You can see one of the tears here, large tear here. you are diathermizing it, you're marking it so that later on you can see that. And then made one single opening at the posterior pole just supranasally. And now there is a lot of subretinal fluid which is below this. Once you remove the vitreous, you have to take the fluid from below the retinal surface. Like I'm using a suction, and the suction tip is inserted within the retina in the subretinal space. And we will be basically removing the fluid from the subretinal space. Like here, I'm using active suction to remove that fluid from below, and the air bubble will compress the retina. So that's called a fluid air exchange, with which you can see that now the retina is almost fully attached all around. And once we finish, this is the central fovea, this is the optic nerve. You can see the anatomical architecture of the eye, which has come back in a retinal detachment. There's a last bit of fluid being removed. And then we will use something called a silicone oil or gas. Here we can see the silicone oil getting injected, and that will tamponate the retina. So that is how you would manage a retinal detachment. This is the final end result. This is the optic nerve. These are the blood vessels. This is the fovea, which is quite normal. This is the temporal tear, which we made and we have lasered. And these are only reflections. The patient's vision improved about 75%. Sometimes there is an inferior tear, which we can laser on the top so that it doesn't go further on. So a laser barrage is possible sometimes in a peripheral retinal detachment. Commotio retinae is otherwise called Berlin's edema. It's basically a blunt trauma causing posterior pole. There's an edema, and the central area, there would not be an edema. And generally with time, it will just go off. So this is a Berlin's edema, you can see, and later on, you can see some scarring there. Hypotonic maculopathy is another condition where pressure inside the eye is significantly reduced and can manifest as disc edema or choroidal folds. You can see this is the hypotonic maculopathy. Traumatic vascular occlusion can sometimes occur because of angiospasm, and shearing of the central retinal vessels in the optic nerve can also occur. Vitreous changes like vitreous syneresis, hemorrhage, etc. can also occur in many cases. Posterior vitreous detachment with peripheral retinal tear, I already told. There could be pigments or blood in the vitreous. So these are all vitreous changes in PVD. Optic nerve injuries to be separately dealt with. It can be prelaminar, laminar, or postlaminar. Most commonly, we call it as traumatic optic neuropathy, in which you may need to give an IV methylprednisolone pulse. This is laminar and post-laminar optic nerve injury, which we can see. This is optic nerve avulsion, the photograph which is seen here. Thank you very much for your kind attention, and thank you.